Again, the things that we'll focus on: small hospitals, multiple individuals involved, and get transferred to a definitive care site ASAP. As we have always said, trauma ends up being somewhat of a team sport. So you'll be, guiding the care or the evaluation by multiple individuals when you're supervising. So basic resuscitation skills, again, A, B, C, D, E, etc. And, figure out, you have to facilitate the communication amongst the team members. You'll have people who will be very outspoken and know absolutely everything about everything, quotes. And then you'll have people who will be very hesitant to speak up, who may be the most knowledgeable one in the group. So you have to facilitate that. And then it should help to build the relationships between some of these facilities and their regional trauma center. And that is one of the real goals. So rapidly decide, and a lot of times this can be done with the scene call prior to arrival of the patients. But they should be able to make a decision. Is this somebody I can keep? Is this somebody I'm going to send home? Is this somebody I need to move on down the road within 15 minutes? Okay, and everybody in this group probably has recognized that so far there's no mention of needing a CAT scan or lab work, okay? And that is very, very true, okay? And then they'll learn how to critique their own process and how to perform some performance improvement activities. We already within North Dakota have an inclusive system. That is, every facility that has an emergency department is expected to participate within the system. Now, it also is eye-opening for some of the faculty members who have not previously resided within North Dakota. You get providers from, the southeast part of the country, the metro areas. They show up and sometimes they wonder, well, why don't you just fly this person to me? Or what do you mean you don't have an ambulance? Well, in parts of the state, there may be one ambulance provider that covers 3 counties. And when the rig is already down the road, they don't have anybody else to call. So it's a real common phenomenon, especially in the western part of the state now, that patients are being transferred by private vehicle even when they have significant injuries, because there's no other way to get them there in a timely fashion. So the audience, it's everybody basically. Course requirements, we kind of already covered this. Equipment requirements, same thing as what you need for ATLS, but less. And then you can upgrade some of the scenarios with the use of mannequins or models. Again, very similar to ATLS. Okay, so the course, the first thing that they see actually is the lumberjack video, which is an example of how to do things wrong. It's an individual who has a chunk of wood impaling their neck and endangering their airway, and everybody kind of runs around in a disorganized fashion and never focuses on the first part of the ABCs, the airway. So, and that happens frequently, unfortunately, to providers who have not had some sort of training. So I think we've kind of gotten past that point, although people will frequently focus on some things that maybe they shouldn't be focusing on. And when kids come in, just throw out the rule book. They just run around and yell at each other. So this is a relatively new edition, about a year old or so. And there's space within the presentations for discussion of the local system, discussion of communication systems, etc. So, as I said, this is basically about loss of airway. Bag patient on the way to the helicopter, failure to utilize oxygen. Roles weren't assigned. Nobody was responsible. I mean, just as, where you work, if no one's responsible, believe me, it may not get done. Even if everybody is supposed to be responsible, sometimes you have to, define the roles. And then you do need to ventilate these folks, obviously. So you need to have somebody who's going to take charge, and that should be the most qualified individual, and depending upon who that is and who's there at the time. Now you have to remember that some of the rural facilities will not have a physician who's there all the time. So it may be an advanced practice provider who might be one of the leaders for one of the teams, and that's very appropriate. So again, prioritization, a repeatable way. You need to have team roles. So, and they're just telling you here that this video is embedded in a slide, but not all systems really, play it well. I mean, there's a Windows format and also a QuickTime format. So theoretically, both of the common operating systems, Apple and Microsoft, should play it. And you'll probably need speakers. So again, a lot of players, a lot of team members. Notice everybody's got some sort of protective equipment on, but this looks like, it's kind of I don't know if it's supposed to be, probably an ED with actually windows, which is, I don't get to see that too often. Our rooms are kind of dark and dingy, no windows, but not dingy, just dark. Somebody would take an affront at that if I said dingy, just dark. Okay, so usually 3 people, but it can be more. And then roles and responsibilities are merely suggestions. They can probably tell us more about how things normally work at their institution. But they got to talk to each other. If they don't talk, and sometimes that means thinking out loud, what should I do next? I mean, what do you think? As opposed to just being strong and silent. There's no John Waynes, there's no Clint Eastwoods in the emergency department during these resuscitations. So we'll have basic needs for equipment, policies, etc., so we can identify what they might not have, okay, and what things that maybe they need. And we need to make sure that things are organized in advance. Now, if we show up with the van, and that's the method that we're using, we'll have some of these problems handled in advance. But we need to replace stuff as we use it or break it. So, primary assessment sections follow the usual and the same format. Okay, the scenario, what kind of things do we need to be thinking about? What are the objectives? What are we trying to teach you? Do we want you to learn about airway? Are we focusing on breathing? Is this a scenario that focuses on blood loss or circulation? How to get prepared, getting your equipment and everything ready. Calling to see if, there are some of the facilities that will have blood products available. How do we recognize these situations? Management and pitfalls. What things that can go wrong? A lot of times they forget that, I'm going to try to intubate, but last time I had the laryngoscope out was 3 months ago, and guess what? The batteries are dead. Well, you replace the batteries and you find out it still doesn't light because the bulb's burned out too. Okay, so nobody had checked it. So those are things that can go wrong. Or you can, start a drug-assisted intubation, and once you get them paralyzed, you find out, hey, I can't intubate, and now I'm really having problems. So the primary assessment now also includes a patient scenario. Everybody's trying to make patient-based scenarios because they're a little bit more realistic. It engages your audience. Lectures are boring, I'm sorry, and here we are lecturing, but That's what they gave us. So we have a trauma patient in each step of the team's management of the various issues. So after the scenarios, each section of the assessment will have a slide that will ask these 3 questions. What do you need? What do you have? And what are your responsibilities? So it makes them actually start thinking about, well, gee, this is something I might not have, or something that we're going to have to order in advance. Gee, maybe this is somebody I got to move on down the road. There's worksheets within the text, and I don't know, how's the text getting along? Okay, good. So that will actually ask them to reflect on needs and roles, etc. And we ask them to complete these during the lecture so they can kind of think about their own facility. And then they'll be discussed during lunch. And you as faculty members, because you will be part of the faculty eventually once this gets rolling, should review the worksheets. And they all follow the same format.
So will we all be instructors in this?
At some point in time,
Okay. We'll get those books.
Yeah, I don't know who's going to buy them yet, but we'll figure that part out. Right now, the RTTDC courses that are being done based within the facilities. I think the overall vision is that maybe portions of the course, or maybe the entire course, may be taught within some of the vans. Or they will be utilized as one of the teaching rooms, within the facility, because not all the facilities are going to have, they would a lot of times.
One ER.
Yeah, they have one bay. And that's going to have to be kept open for patients, because it's the only show in town. So speaking of this, I presented a case, or had a case presented at the recent North Dakota, South Dakota American College of Surgeons chapter meeting, where somebody had a self-inflicted crossbow wound to the chest.
Self-inflicted?
Yeah, me too. It's also, I just reviewed a case, the self-inflicted gunshot wound from the long rifle or the trap gun. You kind of wonder, how do you do that? Is your arm really 4 feet long? But somehow they've managed to do it. And I wondered if it was one of those small crossbows, the midget one, but it wasn't, because it was a full-length bolt. It was 22 inches, which is the long bolt. And by the way, the projectiles from crossbows are not called arrows, they're called bolts or quarrels, okay? So anyway, it was removed appropriately, etc. What you actually try to do is take them to the operating room, open them up, cut it in half, and pull each end out separately. The end with the fletching or veins, and then the end with the broadhead on it, because a lot of times they are not the target version that they're shooting themselves with. They're the broadheads, which some of them self-deploy and expand, and they're big. They have very sharp cutting surfaces, so you don't want to just grab it and try to twist it off. They thread on, but there's actually like broadhead wrenches, but most hospitals don't keep each version of the broadhead wrench in stock, so we'd probably have used pliers, So anyway, interesting. So I just, after the questions to consider each section of the assessment, we'll have a slide listing, the learning objectives. And each of the primary assessment sections will have a couple slides, on facility and faculty and team preparation. So that is actually one of the questions on their worksheets. When we're doing this, make sure that the instructors and you guys allow everybody a couple minutes to complete that, because that's part of the process where they think about things before they do them, because that step is very important in learning, because you want to have an involved audience because they retain more of the information than if you just present them with a lecture, like we're currently doing. So after the preparation slide, there's an assessment slide and some further slides on A, B, C, Ds, and E's. And there's a little section on a flail chest, and it'll keep playing and playing and playing till you go to the next slide. So that's one of the pitfalls in the slide presentations. It's a short thing. And I actually brought some of those things with me, so if we have enough time, I can show that to you. Or otherwise, what we need to do is get people from the region out to see some of the first courses that are put on, so that's what ends up making you an instructor, because you participate in a course. And then there's also an embedded video of an intubation, and hopefully we can get it to play. And then there's pitfalls. Pitfalls are really, really important, okay, because they highlight things that frequently do go wrong and that they need to be aware of. And a lot of times it's not in the psyche of some of our providers to think about, gee, what can go wrong, okay? Now, in surgical training, that's one of the very first things that we're all taught. And if you've worked in an ED, et cetera, you know that, gee, stuff goes wrong all the time, and I'm paranoid about it, and is it going to be me, that's going to be blamed?
Did you have anything that you wanted?
No, it'll be on a whole different presentation. Okay, so we'll have responsibilities defined, just suggested. They may wish to change them.
What happens if they don't change?
If they don't change them?
What if there's a glaring, obvious, error? Let's say a physician that walks in and rips out the neck collar without checking C-spine first all the time, every time.
So
You
you
guys come out and do this, and they don't change. Is there any repercussions?
well, so no, that's not changing. They don't get to change the scenario. It's just responsibilities. So that would be part of the, a self-assessment. You'd say, okay, so Dr. Doofus removed the cervical collar. Now, what do you think? Is this the best time to do this? And if so, why? And if not, why? And what do you base clearance of the cervical spine on? Okay? And by the way, that is something that's real,
It does
happen all of the time.
Your lead, do you just, that's okay? I mean,
No. No, I would never actually say it's okay.
No, but
What-
I mean, do you have any repercussion to them? Do you say, you really, why should they have to listen to you? Make sense?
Because their hospital is paying money so that they will be there. Right, right, right. Well, but there is a state PI process,
Okay,
okay?
Like regional.
Right.
okay, yeah, okay, all right.
And then the other thing is, most everybody comes to these. Now, they might have an attitude, okay? There's no doubt about that. Yeah. But they do come to do a good job when they come to work every day. So we do have that in our favor. Okay. And the way, you just have to figure out the best way to present it to them, that this probably is not the best way to do it. Okay. And, you may have to rely upon one of the physicians, and I know the trauma directors, who are some of my first instructors, are all over this particular issue. Okay. All right. Yep.
Thank you.
And we may actually develop statewide guidelines for this. Okay. But personally, I like to see all my patients come in with a C-collar from the critical access hospitals, because there's no way in the world, if they're sick enough to come to us, that you can probably clear their C-spine. They're either drunk, which is everybody after about 8 p.m., and before about 10 a.m. They're under the influence of drugs, or they have a distracting, painful injury. They got an open femur fracture. It's hard to concentrate on your neck spasm when you got a chunk of bone hanging out and bleeding. So, but sometimes it does take kid gloves. So you just have to do it with sensitivity, touchy-feely. Okay, so after this roles and responsibility, the instructor will pause for questions, after which the assessment sections will have slides to summarize main points. And sometimes, you know, if we see something that's been done wrong, or we realize that this facility is a place which frequently sends patients in without cervical collars or without airways or without chest tubes, we can highlight some of those things. Because believe me, I mean, the instructors from the level 2s that receive patients from these places already know their characteristics, okay? So early transfer is a major emphasis. Goal is 15 minutes. Now, we need to have that one on a revolving slide presentation because that is one of the chief issues within every state in the union is don't hang on, don't futz. You don't need a CAT scan usually. Now, there are times where the decision to transfer is based upon the CAT scan. You know, the 15-year-old football player that got knocked out on the field came in with a GCS of 15. Seems great, okay, and yet you do a CT and he's got a hemorrhagic contusion. Well, you know, I don't really like to see those sitting at a level 4 or 5. You know, send them on down the road so in case they have problems. You know, or if you have an OBS unit and you're only 10 minutes away from a level 2, well, maybe you could hang on to them there and then transfer them if something happens. But for the most part, that does not happen within our state, and you want them to get them down the road. Stress the knowledge and their capabilities and what their resources are, okay? If you can treat it definitively, you can keep it. You can study it. If you can't, that probably, you know, is just a delay. Time is of the essence. Grandma, when she comes in after falling and she's on a pound of Coumadin a day and has an INR of 10, doesn't need to hang around for a CAT scan when she's got a GCS of 8. She needs to get moved quickly. If you have fresh frozen, TXA, activated factor 7, fine, give it to her. Nobody has that around the state right now, okay? Because number one, you need resources for fresh frozen. Number two, you need a big chunk of change for activated factor 7. And TXA hasn't been approved by the FDA for use in all situations. So there's a couple slides on screening and brief intervention for problem drinkers. And then we'll have some local system. Yeah, that's, you know, a big portion of the population. North Dakota's been pretty soft on enforcement of DUIs, as you all know. So is Minnesota. And some of that's changing. And then we'll discuss some of the local systems, and that'll be basically prepared by the faculty prior to the course. And then again, another worksheet that makes them reflect on what's going on. And that's part of the learning process. Okay, so we've updated the section on pediatric trauma in this version of the course. There's actually a pediatric scenario. And then I think you can point out some of the issues, you know, the pitfalls where, you know, every mother who works in the hospital or knows somebody in the hospital might be calling in on the cell phone to find out if it's their kid, okay? At where I work, which is here in Grand Forks, we frequently have a bunch of the nurses come down to the ED if they know that there's a pediatric trauma, just to wander through and see if it's their kid. Because you know, you wouldn't get notification if they're injured because they're not on their cell phone at that time. So anyway, so that happens. So crowd control. Now, the priorities are the same with kids. The difference is their anatomy and their physiologic triggers and, you know, the equipment that we need. So those are the things. I mean, these priorities are the same for every patient. It's just that the triggers and their physiology may be a little different. So that's the nice thing, is you need to remember the same stuff irregardless of the patient. Okay, and then we have a special consideration section talking about pregnancy, burns, geriatric trauma. Okay, now, one thing I might mention, okay, pregnancy, Also, athletes might be in the special consideration sections. They do not get tachycardic. Same with pregnancy, because they get a hypervolemia, okay? And their hemoglobin starts out a little bit lower because of the hemodilution and the expanded plasma volume. But you got to remember that you're treating 2 patients, and the best way to treat the baby is to treat mom. Okay, but mom might not show physiologic side effects of her hemorrhage as early as the fetus, okay, because the placenta survives on venous oxygenation, basically. It's maternal venous blood providing the oxygen supply. So you don't have that PO2 or that O2 sat of 99%. You basically have venous sats. Okay, the reason it works in babies is they have fetal hemoglobin, which has such a high affinity for oxygen that it will be offloaded. Okay, that's the reason it works. Okay, so we have to, that's why mom, when she comes in, gets oxygen, gets tilted to the left side so that she can perfuse the placenta. So that, some of these sections have been expanded. Okay. Also, the geriatric population may not show signs of pain. Okay. They just stop breathing. Okay. They just splint. Okay. They don't get tachycardic because they're on a ton of beta blockers. They bleed. Their skin is fragile. And interestingly enough, they're under triaged, almost every state in the country, and they don't get transferred to definitive trauma care facilities like level 2s and level 1s with the same frequency. If you compare the injury severity, you know, if you're grandma and you fell and you broke, 12 ribs, they might be watching you in the ED, where if you're a 2-year-old, man, you are out of there on a helicopter as soon as something can arrive, okay? All right, it's just because of the way society works, okay? Again, boy, there's a lot of emphasis on worksheets, isn't there? Yeah, boring. Anyway, but they're very useful, okay? And it allows people, it's part of how adult learners learn. How do adult learners learn? Anybody know the difference between a 5-year-old and a 35-year-old?
Repetition.
Yeah, repetition, experience. But, for adults, we have to get past the barrier like, why do I want to learn this? Who's this, bozo? What do they have to teach me? Do I really need to learn this? A 5-year-old is like a sponge. It just soaks in. Plus, they have a younger brain. It's all downhill after 17, I tell everybody. Anybody here under 17? Sure. Okie dokie. Yeah, all right. Off of the Haldol today. So, something new is actually the performance improvement and patient safety goals for this edition of the course. And what we will do is ask the participants to kind of critique what's going on and explain how this process may help their performance and help the performance of their center. One of the real keys, trauma centers fail accreditation or verification primarily because of lack of performance improvement. 86% of the time they fail because of they don't know what this is or how to do it right. Okay, and that means that there's an ongoing process that they actually look at their own performance. Things that we examine, we tend to improve. If we never look at it or we just ignore it, we don't know that we're doing a bad job. You can go into a hospital and say, what's your outcomes from appendectomies? And they say, good. And we say, how do you know? And they say, well, we've never had a problem. Well, how do you know you don't have a problem? Did you compare it to, the place in Minneapolis or Rochester, or do you compare your outcomes nationally? And if the answer is no, they haven't really benchmarked themselves against anybody else. So you don't know. Maybe they've always been doing a great job. On the other hand, maybe they've always done a bad job, and they just have never recognized it because it hasn't changed. It stayed bad. So anyway, so this is really a key for how places and performance improves. So, and a lot of times the facility that will help their PI is their local trauma center, and they will know who that is. And in some cases, it might be two places. I mean, if you're in Dickinson, and I just refer to Dickinson because I was just there a couple days ago, it's basically the two facilities in Bismarck, okay? And some days it might be one, some days it might be another. It might be availability of transport, vehicles, helicopters, etc. Or you got 10 victims and you got to split them up because no one place can manage all 10 at once. So the thing is, we're not trying to find fault, we're trying to save lives. Okay, we're trying to say, it's just like, pulling off the C-collar. It's, gee, you stupid idiot. No, it's, well, is there a different way to do that? Now, is this the best way? Why did you want to remove that? Okay, so believe me, in the back of your mind will be, you stupid idiot, but nevertheless, don't say it. So there's a little overview on communication issues and how to make the communications. I mean, certainly, when they're getting ready to ask for transport or to move the patient to a definitive care site, they need to be talking to the trauma surgeon on the other end. And I would stress that for you guys, it should be the trauma surgeon or the ED doc, not the subspecialist, because there's a lot of times other injuries and the subspecialists tend to treat one organ system. You transfer the patient with the head injury to the neurosurgeon and they forget about the spleen. And they're dead 2 days later because they can't really keep their heart pumping with a hemoglobin of 3. So, it's the best place to get them. Plus, besides, they won't get refusals from the trauma people. They might get refusals from the subspecialists. So, and we will make our subspecialists show up. The trauma surgeons in the state will call them and say, hey, here's what I got. And if they say, I don't want to come in, then we say, hey, I don't really care what you want to do. You need to get over here and see them. Those are the requirements if you want to be a member of the medical staff. So, and then there's some federal laws as well. If you're listed on the call schedule, you actually have to show up and evaluate the patient. Okay, and if you don't, it's I think a $10,000 fine for each section of the occurrence that you do not follow. So one episode could be, tens of thousands, not just 10, tens of thousands. And usually that makes sense to everybody, even at 2 a.m. Okay, and everybody goes out of their way to manage it when, like where I'm at, we tend to only have one neurosurgeon around at a time. And I understand that. And if it's somebody who doesn't need, an immediate intervention, we will manage that for them. Okay, that's also the reason to call in, because they've concentrated resources in the hands of the trauma services. Not, a lot of times we have one neurosurgeon at a time. We only have one orthopedist. They might have a crap load of elective cases the next day. They don't want to be up all night, but a lot of times they don't have to be. So if it comes to the trauma service, we will try to deal with it for them. So that's something to emphasize when you're teaching the rural providers. Do not bypass the trauma system. Call appropriately. ED, they don't turn you down. Trauma shouldn't turn you down, okay? Everybody else, I don't want to go out on a limb and promise results. There'll be some communication videos as well, and again, embedded in the slides, and usually they will play. It's getting more common that things play and not, as opposed to not play, unless they have, Windows 98 on their computer, and then we might have issues. So the first scenario is bad communication on both ends. Second, bad communication from the trauma center, good communication from the rural hospital. Good communication from trauma center, bad communication from the rural hospital, and fourth video, good communication on both ends. And that's obviously what we're looking for. And then all throughout this, allow time for discussion, because that gets your audience engaged. When they feel like they're part of the group, they're more likely to volunteer information and more likely to be paying attention instead of dozing. And then we'll do these team performance scenarios. There's 3 scenarios included with the course. And occasionally a facility will want to do one of their own scenarios, or will want to do one of their own scenarios because we received a patient which maybe wasn't managed ideally. So we might substitute one. And they might be specific to the facility, maybe, you know, the demographics, industry, or a mass casualty situation. There is a suggested sequence of lectures and rotations within the text. Your faculty members need to set the stage and kind of be somewhat familiar with what's going on. Providing, just like I was talking about the patient with the crossbow injury, you tell them a little bit about the history, physical findings. Not everybody's utilized simulation a whole lot in the past, so sometimes it's very artificial and they need a little encouragement, and they need to get used to the fact that if they're going to be doing something, they got to think out loud so we really know what they're doing. Like, you know, I'm going to don protective gear and I'm going to inspect the airway, because if you actually have a live person, they're probably not going to stick their finger down and pull their tongue forward and sweep their airway to really make sure it's clear, unless, you know, they really trust that person. And then you need to be able to, you know, feel free to speak up and say, oh, now, you know, you might want to include this, or, you know, if you're really checking the C-spine, you need to do a little axial loading, and, you know, just some hints. And also make sure that you get the whole team engaged to critique their own performance as they go along. So, and then here's where we utilize the imagination scenarios, you know, if they're not in their own ED. Hopefully most people are going to be close to their own facility when this is going on. So they need to communicate amongst themselves to get things organized, to make sure that they're utilizing the knowledge of the various individuals appropriate, and that they're communicating their decision making. Okay, and then there's an optional prevention video as well, if there's interest and time. Now I got to tell you, these courses have, over the past 10 years or so, have gotten significantly longer. They started off as maybe about a 4.5 to 5 hour course. Now it's up to 8.5 hours, which ends up being a full day. The one we're doing in Hettinger, we're starting at 7:30 and not finish. I mean, the estimated time that we finish is around 4:30 or so, after, you know, we break up and discuss the results, etc. So, and we've worked in time for the prevention videos and things like that, but it will require internet service because you have to link. So, and then you can, you know, they can't be saved. So, and that's okay too. So when you do the summary, that's an opportunity for people to ask questions, tell you about, you know, their worst memories, their fears, etc. Are you going to pick on me? You know, Big Brother's watching. We don't have enough money to have a laryngoscope, or whatever the issues are. And some of the facilities truly will have issues, but for the most part, you know, they really want to do a good job. Make sure that you get your evaluation forms, and then completion certificates if they're already have been pre-prepared. Policies. They have to be approved by the RTTDC chair, okay? He's in Des Moines, Iowa. He's easy to reach. You can reach him through the national office. But that'll be, I mean, we'll do that on the state level, usually. There's an online course management system for whoever the coordinator is. And then we generally want one instructor team one instructor per team for the scenario. So if you're running 3 scenarios, you need at least 3 instructors. And you can have teams from more than one facility. So if you have 2 rural facilities that are 50 miles apart and each one wants to send 4 or 5 people, it may make sense to hold it at one facility so that you don't have to make multiple trips and put a course on for 5 people, but have to put the course on twice for 5 people each time, because you're going to take multiple instructors, etc. So and it is time consuming. So that's something that we have to see how that's going to work out. So course director for the RTTDC courses is generally a physician, preferably a trauma surgeon. It can easily be an ED doc as well, and that's happened in some cases. One of my busier instructors when I was in Wisconsin was a ED doc that I knew that I had trained, and he put some courses on, and a lot of times we would just drive up for half the day and make sure things were going well, participate in some of the scenarios, and then drive back the other 5 hours to get back to our own facility. So it kind of depends upon what the how many instructors are available, but certainly we want them to at least have completed an ATLS course, and the course director participates throughout the entire course. Course coordinator needs to be knowledgeable about what's going on in the trauma world. Early on, we're probably going to be using ATLS coordinators because they have already been through a lot of the course, organization and management. They know, a lot of the problems and pitfalls. They will probably enter the course requests, add the list of faculty, etc., order the course texts, and ensure that CME requirements are met. And then they're going to work with somebody from the local hospital to make sure all the arrangements are made and that we have the capability. The course that we're doing in Hettinger on May 18th, it'll be the first one within the state. All of these things have already been taken care of. And then we'll have a local facility person who's going to work with the coordinator to distribute the pre-course questionnaire, get the course text to the participants a couple weeks ahead of time, and will help the RTTDC course coordinator in getting all the documents after the course and getting them back. And whoever the course director is has to approve the instructors, okay? And as you can see, it can be all sorts of folks, but basically people who have some experience, with dealing with emergent issues in trauma care and are enthusiastic. You're all enthusiastic because you showed up after lunch. You're familiar with the course material and adhere to the concepts. And it's about 8.5 CMEs or CEUs. They're Category 1 credits, so they're valuable credits. And then there is a certificate of completion, and there's lots of paperwork. There's disclosure forms. If we get some sort of commercial support, and I haven't seen any dropping from the skies lately, you have to acknowledge it. So, but you can get support in the form of grants or equipment or things like that. I mean, you could have GORE, give you a projector or something like that, as long as it's unrestricted. So right now that hasn't happened, and I'm not sure it's going to happen, but our aid is probably going to come through the state and the Committee on Trauma in North Dakota. We bought Trauma Man, a few years back, and they're $30,000 a piece. So the state COT spent their funds to buy Trauma Man for the state, and we maintain it with a maintenance contract and buy the tissues, and that is part of what's probably going to get used on a lot of these courses for airway interventions, chest tubes, etc. CME, you know, all the things that need to be, here the ACS seal, okay, and that's, you know, the big round thing, not the thing that claps its hands and eats fish. So they're spelled the same. I always thought that would be kind of interesting, though, to have the seal. And don't change things, okay? It has to be approved by the ACS Trauma Programs Office. Course, anybody want a break for a few minutes?